My name is Munjid. I'm an orthopedic surgeon. I come from Sydney, Australia, and I do hips and knees, and they're boring like bad shit. But I have interest in osseointegration. Is that the right door? Where's the podium? There you go. Okay, so let's put the summary very briefly. I don't have any complications. Okay. Oh, I said yesterday, actually. Wasn't it? Okay. So, yeah, I mean, look, I'll talk to you about my fuck-ups and the stuff that can go wrong, and then I'll talk to you about complex cases. And to be very frank and blunt, people who tell you that they don't have complications, turn your back to them and move away, because everybody gets complications. And if the person has no complication, then he hasn't had enough experience and hasn't done enough. So I do have disclosures. This is my favorite patient, by the way. Oh. And I do design implants and things like that, so I do have financial interest in what I'm going to talk about. Actually, he's a complication. The implant fell off. He broke the implant because he was so heavy, and he had a titanium 3D printed implant size 9, I think, and he broke that one, replaced it with chrome cobalt one, and didn't integrate. So unfortunately it didn't work, but he was very happy for 6 months. So that's my first complication. Okay, so I'm going to talk to you about pushing the boundaries. This one of my patients is Jason. He's living in Whistler most of the time, and he's crazy. Osseointegration did change his life, and actually amputation did change his life. He lost his legs as a result of heroin overdose, and he had crush injury, and he was completely in a dark place. But then he woke up without legs, and he became an inspiration for a lot of people, and now companies sponsor him to do sports like snowboarding and skiing, and he traveled around the world. He became very famous, actually. So I'll talk to you about the boundaries that we're pressing and pushing. Single-stage surgery. I'm the one who started single-stage surgery in the world, and everybody criticized me about doing it. I don't regret it, and I think it's the way to go. Vascular disease, people roll their eyes when they saw me doing vascular patients, and we have very good success with it. Osseointegration with total knee replacement, that's a really major fuck-up, and I had failure in that, and I'm too scared to go back to it, and we have 4 cases that failed out of the 8 or 9 cases that we've done. Osseointegration with total hip replacement is a great success, and everybody with a hip replacement that we treated has done very well, and I don't know why. Severely osteoporotic patients, patients that really have hardly any bone left, and people with congenital amputation, and they are the ones that are very tricky, because they were born with an amputation, they didn't see anything better, and then you try to make them better than what they were beforehand, and that can face a lot of challenges, especially that psychologically they're not prepared to walk like able body, because their amputation is their able body, and you're dealing with very compromised bone, very small bone, children bone or infant bone, and trying to work around it is very difficult. And then short residuum. Size does matter with amputation, unfortunately, and it is a major problem when you deal with short people and short amputations. So figures, I mean, I was criticized that I'm doing too large numbers, but I don't give a shit. We've done 517 in Australia so far, but majority of them are males, and that's because males are crazier and they go on motorbikes. Motorbikes are not compatible with human beings, but that's a different story. Majority of our cases are transfemoral. We have done few transhumeral, few transradial, and we have done a lot of transtibials. Now, country distribution, you can see majority of my patients are from Australia. The second largest country population are from Iraq, and the third, well, depends how you look at it. If Trump invade Canada, then you will be more than Iraqis, but you can see that number can change, and it depends on when the wall is going to be built. Oh, the wall is being built on the other side. Okay, so that's the distribution in the United World of America, and you can see we have done cases, patients from all around America, and when you look at your next door neighbor, Canada, distribution in Canada basically. When we started in 2010. Literally speaking, we started in 2009. We did one case, and we monitored that case for a full year, and we chose it very carefully, and then it was thought to be a hobby, and I'm going to do one, and then achieve my childhood dream, but then it worked, and then I did 4 cases the year after, and then from there onward it became a reality, and now we're doing hundreds basically, and the numbers will keep going up. Again, that's a distribution based on a level of amputation, and you can see that we started transhumeral and now transradial, and we haven't embarked on. We've done fingers, but that doesn't include in this study because I do it with plastic surgeons that work with us in Sydney. Majority of amputations are due to trauma. We have done 24 vascular cases, and they are the ones that have our biggest attention, because if we prove that vascular patients with osseointegration works, that will be a game changer in the world of amputees. And I will have assassinations attempt on me by the socket makers, basically. So, because until now, osseointegration, they look at it as something that, oh yeah, it's for these traumatic patients, the ones that we don't want anyway. We have all these vascular patients that we can deal with. But if it works in vascular patients, then it's completely will change the game for the world of amputees, basically. And it will be better for everybody around the world, because it becomes the norm, basically. We have done a lot of bilateral cases, and bilateral amputees, especially bilateral lung knee amputees, are the most challenging cases, and they are the ones who struggle more with mobility. And sorry, it's going. But still, the majority of our patients are unilateral amputees. Now, let's talk about stuff-ups. So we revised several patients. So we have transfemoral revisions. We have 10 cases, and unfortunately, until last week, I could say proudly I haven't revised a single femur due to infection, but I revised one now, which I did just a week and a half ago. He's an American patient, and he flew to Sydney, and we took the implant out without damaging his femur. He had offers from different places in this country to have it revised, and and then he decided that he wanted to come to Australia to have it done, and we did it in Sydney. Lucky we revised it without damaging the femur, and he's going through antibiotic phase. He will go through 6 weeks of IV antibiotics, 6 weeks of oral antibiotics, and then 4 weeks of holiday, and then we re-implant him with a new implant, hopefully in 3 months. So we had failures to integrate 3 cases, and they are the ones that I had my learning curve, and I undersized the femur, and they are purely my surgical mistake. We had 2 implant fractures where patients have broken their actual implant, and both of them are very heavy users, and both of them had the chrome cobalt German implant, the old design, and both of them were size 15, very small size, on 120 kilos muscular guys. And I'll show you the pictures and the videos of them both, they both got revised. One patient had failure to integrate due to a radiated bone, and that was a pure experiment by the patient, and the patient has a through knee amputation, and he didn't want to lose any length, and he had a radiated bone at the age of 9, and it's an absolute contraindication, and he said, I don't care, just try it. I put the implant in, the implant didn't take. After 2 years we had to shorten him and into a healthy bone and revised it, and he's done very well since. And we had three patients where they had loosening of the implant with time, within a year, and all these cases, all the revisions, with the exception of the implant failure, happened in the first year after the surgery. So for people who had osseointegration that passed the year, you're fine. Okay. Now, when it comes to tibias, it's a much bigger complication rate. We have 12 failures, and the 4 total knee replacement with the osseointegrations are my biggest failures, and that wrecked my statistics dramatically. These are 4 out-straight failures, and they all converted to above knee amputation. And despite that, I have now patients asking me for a knee replacement with osseointegration. I'm saying no, I can't do it at this stage because I'm too scared to do it. I had 5 infected tibias that were revised, 3 of which had re-implanted, and 2 of which are still not implanted, and one of them is sitting in the room. We had 2 aseptic loosening, and we had 1 failure to integrate, which was a case that, again, I undersized tibia. So at 6 weeks mark, he's an American patient. I don't know why it's always happening in American patients. That's not a good thing to say, is it? Sorry. And at week 6, he couldn't put weight on it, and we revised him straight away, and he's doing very well. So the complication rate in tibia is much higher than the complication rate in femurs. So if you look at all the cases that we've done, we had 159 reoperation. Now, some of these reoperations happened in the same patients again and again, and they distribute among the patients in the form of 43 debridements, and these debridements happen mainly in the 2-stage surgery. When I first used to do 2-stage surgery, and a lot of these patients have 5 or 6 debridements, and that's purely due to infection. Then you have 34 neurectomies, and whether these patients needed the surgery because of osseointegration or whether because just the neuromas form, that's the question. Okay, and then you have 45 refashioning where the patients develop redundant skin, and we had to take more tissue, just soft tissue, and there are 23 revisions that I mentioned, and we had 23 revisions. If you look at it, I mentioned 10 femurs, 12 tibias, and 1 humerus, basically, and we had 14, I think it's 15 fractures, William, rather than 14. So there's 1 more that wasn't added, just had a break. Okay, so if you look at the patient reoperation rates in the 2-stage surgery, which is the first group that I did, the first 85 patients that I did, 41% of them. So the bulk of the reoperation happened when I was a baby, okay, learning this. And that's very important. That shows you the learning curve for surgeons. So when you start doing surgeries on people, you get very high failure rates, and you get very high revision rates. So when I first started, I was doing 2-stage surgery, and I was just trialing this. My reoperation rate was 41%, so it was very high. And then when we got the single-stage surgery, which is since 2014 onward, the reoperation rate is 21%. Okay, so that dropped dramatically.